Hello everyone, I'm Dr. Devesh Bhargude. I'm a cardiology resident at Jayadeva Hospital, Bangalore, and here I welcome you all to my channel where we talk about core cardiology concepts. So without further ado, in this chapter we're gonna discuss the topic of chamber enlargement, and there are two terms: chamber enlargement and hypertrophy. So what is the difference? So basically, we use chamber enlargement especially for atria and hypertrophy or enlargement for ventricles because when the atria grow in size, they don't grow in mass, they don't grow in the size of the cavity. So the enlargement is the more appropriate word. So we're going to talk about both right atrial enlargement and left atrial enlargement. So before we jump onto the particular topic, let's just understand normal P wave, how it looks in the frontal plane, which is your leads 1, 2, 3, AVF, AVL, and also in horizontal plane, which is your chest leads. Also in frontal plane, how your axis is going to be. Let's say this is your SA node, and as the impulse generates, it first activates the right atrium and then the left atrium. So it's traveling. The axis is more, we can say it's 45 to 60 degrees, and we all know that the lead, which is corresponding to it, is lead 2. So P wave is always and always going to be upright. The sinus P wave is always going to be upright in lead 2, and the highest amplitude is seen in lead 2. Okay, because it's growing in that direction. Now next is the contour. As I've drawn here, the contour of the P wave is going to be very smooth, like a mini tomb, right? So this is how the contour of the P wave is going to be. Coming to the amplitude, the thing with the amplitude is it's going to be less than, this is the amplitude, and this is going to be less than 2.5 millimeters, or you can say millivolt as well. So amplitude is always less than 2.5, and it's the rule of 2.5 for sinus P wave. The duration, this is also going to be less than 2.5, which you can say roughly 3 small boxes as well. So amplitude and duration is important to us, which has to be less than 2.5 if it's a normal sinus P wave. Coming to the horizontal plane, which is your leads V1 to V6, the P wave is going to be upright in most of the anterior chest leads as well. So V3 to V6, it can be upright, while V1 and V2, they can have biphasic P wave for like upright first portion and inverted next portion. This is going to be because of right atrium, and this is going to be left atrium, or it can be totally inverted as well in leads V1 and V2. Okay, so this is going to be how the normal sinus P wave is going to look like in both of your frontal plane and horizontal plane. So in this chapter, we're going to discuss first the right atrial enlargement. So what you want to know is in a normal P wave, the first component of the P wave, let's say this is a P wave, the very first component is because of your right atrium, and this component is because of your left atrium. So let's see what happens when the right atrium enlarges. Okay, so what you need to know is right atrium enlarges to the right and down. So this is to the right and down if you consider the frontal plane. So in this plane, the RA is going to go right and down. But if you cut me like this, which is your horizontal section, the RA grows anteriorly, and again, this is your right and left to the right. So what happens is the axis, as we all know this, let's say this is your SA node, for example, and the normal axis is going to be like this. What happens to the axis is from SA node, if it was normally going to be like this, when the RA enlarges, the axis shifts, and the axis shifts to right. Okay, so as you all know, this is SA node. Your leads 2, 3 and 1, 1, 2, 3 are placed like this. So P in the lead 3 is going to be taller than P in lead 1. when there is RA enlargement because the axis has shifted. Now, what happens to the contour? Contour of the P wave is peaked P wave. So the P wave, which was supposed to be smooth, round contour, has become tall. It can be peaked or slightly peaked. Okay, what happens to the amplitude, which is very important? So the amplitude of the P wave increases. So normal, as we all know, normal amplitude of the P wave is around less than 2.5. So that is the differentiation factor because the P wave amplitude increases more than 2.5 mm when there is RA enlargement. And this is what we famously call as P pulmonal. Why P pulmonal? Because we all know that the most common causes of right atrial enlargement are going to be your pulmonary diseases which are affecting your right heart, that is called pulmonal. What happens to the duration? The normal duration is less than 2.5 mm, but in the right atrial enlargement, there is no increase in the duration of P wave since there's isolated RA enlargement. If it's associated with LA, there can be duration which is increased. So the duration remains less than 2.5. So the highlighting factor, the contour is peaked, P3 is more than P1, and amplitude is more than 2.5. So these are the three important features of right atrial enlargement. So now coming to the horizontal plane, what exactly happens when there's right atrial enlargement in leads, for example, V1. So as we all know, in V1, the P wave can be normal, which is upright. It can be biphasic or it can be inverted. So when there's RA enlargement, there's usually no affection in lead V1, right? Even the depression, the thing with the P wave, which is very important, is what you need to remember. So if it's inverted, it is again less than 1 mm in duration and less than 1 mm in amplitude as well. So if the P wave is inverted, it has to be less than 1 mm in duration and 1 mm in amplitude. So the changes in V1 are usually not less marked, and the horizontal plane will not show you a lot of changes if there's a right atrial enlargement. So what you need to remember is lead 2, 3, AVF are the best leads to know if there's right atrial enlargement because they will have tall P, peaked P, pulmonary. I know this looks a lot of messy, but that's all about right atrial enlargement. Let's quickly revise the causes of right atrial enlargement. So RA enlargement is mostly because of your pulmonary disease, patient having COPD, emphysema, any obstructive airway diseases. It can be also acute. Acute presentation with this tall P pulmonary can happen in conditions like your acute pulmonary thromboembolism. If there is a massive, let's say, tricuspid wall diseases, a tricuspid regurgitation, which could be rheumatic, or there's pulmonary hypertension due to any cause, causing the RV enlargement and subsequently RA enlargement. So all of these are the causes of your right atrial enlargement. And how do you treat it? It's simple. You treat the cause. You don't need to treat the P pulmonal as such. You just treat the cause and it'll settle. So in the previous one, we studied right atrial enlargement, and we are covering the topic of chamber enlargement. So let's see what happens when it corresponds to the left atrial enlargement. So it's very easy. As we've seen, we know the normal P wave looks like this. The first half being RA, the second half being LA. So LA gets activated after RA because the SN node is like this. So let's see what happens in the frontal plane. Frontal plane being leads your 1, 2, 3, AVL, AVF, and AVR as well. So what's going to happen to the axis when the LA enlarges? So what you need to know is this is the frontal plane which I've drawn, and this is the horizontal plane. So in the frontal plane, LA goes to the left. right? When it enlarges. Unlike the RA, which goes to the right and down, LA goes to the left. In the horizontal plane, LA is going to go to the left as well as it's going to go behind. So if I cut myself like this, is the LA goes behind the posteriorly and also laterally. This is what happens to the LA enlargement anatomically. So what's going to happen to the axis? So let's say this is the axis. In RA enlargement, we saw the axis which was supposed to be like this, gets shifted to lead AVF, right? There's a rightward shift. So similarly in LA, the axis is going to go to the left. There's a leftward shift to the axis. So it's going to be less than 45-degree. And we all know the lead 1 is placed here and lead 3 is placed. Sorry, this is going to be lead 2, lead 3 is placed here. Since the axis is going to be go towards lead 1, you're going to have P1, which is going to be bigger than P3. So the P wave in lead 1 is going to be more than the P3. That's when it comes to axis. Next, what happens to the contour? So this is what the differentiating factor, or what we can tell helps us differentiate which chamber is enlarged. So we all know RA enlarges, RA gets activated before LA. So the RA activation happens normally, but there's an intra-atrial block. Intra-atrial block means since there's LA enlargement, it's going to get more time to get activated, and that time lag is shown by slight hump in the P wave, and then the LA gets activated again. So this, which looks like letter M, is called as M mitral, because I think most commonly in the past, the most common reason for left atrial enlargement was being mitral stenosis. It has been named as M mitral. So this is going to be called as M mitral, which looks like your letter M. What's going to happen to the amplitude? As you can see, there's not a lot of changes in the amplitude, so it's gonna stay less than 2.5 mm. Unlike your RA enlargement, where it peaks and goes more than 5 mm. This is the thing with the duration. We studied that in RA enlargement, the duration does not increase, but the amplitude does. While in LA enlargement, the duration is gonna go more because of this intra-atrial block, or time taken for LA activation. So the duration is going to be more than 2.5 mm, which is roughly equivalent to 100 milliseconds. So what we understood as well, then whenever there's left atrial enlargement, your axis, the lead 1 will have taller P than lead 3. There will be M mitral, and M mitral is best seen in inferior and lateral leads. So your V5, V6, lead 1, and the inferior is going to be lead 2, lead AVF. They will show the best contour, the M mitral of your left atrial enlargement. The duration, as I said, is going to be more than 2.5 mm, right? Which is more than 100 milliseconds. What happens in horizontal plane? So we saw that in RA enlargement, there was not a lot of changes in when it comes to horizontal plane, horizontal leads like your V1. But the thing with LA enlargement, in V1, you can have upright normal M mitral, you can have biphasic or inverted. So what, like it's just like before, isn't it? So but what happens, the difference is this inverted P wave is going to be more than 1 mm deep plus more than 1 mm wide. So whenever there's inverted P wave, because of left atrial enlargement in lead V1 or V2, is going to be more than 1 mm. We know that normally when there's no chamber enlargement, If the P wave is inverted in lead V1, it's going to be less than 1 mm in both duration and amplitude. But that's what gets deepened and wider whenever there's left atrial enlargement. This, if it's biphasic, this portion is because of right atrium, and again, this portion which is because of left atrium is gonna go deep. So this is what happens in horizontal plane. Simply asked, if you want to recall left atrial enlargement, talk about a mitral in lateral and inferior leads, and you can talk about duration that is going to be more than 2.5. These 2 points are very important when you want to understand hem mitral. So what happens when the both atrial chambers are enlarged? You have both right and the left atrial enlargement. So the ECG is going to show features of both, and that's going to be mostly seen in leads. Let's see your lateral leads and inferior leads. So your 1, 2 AVF, and in the horizontal leads, the V1. So because of your right atrial enlargement, let's say lead 1 will have tall. So forget the right atrial enlargement. Let's say all the leads will have this kind of picture in lead V1. V2 will have tall, slightly taller right atrial enlargement component, which is seen in the ECG with slightly tall peak, and that is followed by left atrial enlargement, which is slightly followed by notch, and the increase in the duration of more than 2.5. So all the leads will have increase in the duration of more than 2.5, which is because of your LAE enlargement, and there can be amplitude risen to more than 2.5 because of your right atrial enlargement. So this and this both changes, and usually they're gonna have configuration of a mitral because of your left atrial enlargement, and in lead V1 is gonna be either biphasic or inverted, right? This is the RA component. It's gonna be tall because of RA enlargement, and this is gonna be deep of more than 1 mm. Similarly here more than 1 mm if it's biphasic, or if it's inverted. Both times it's gonna be either biphasic or inverted, but more than 1 mm in lead V1. And that's it, folks. That's all about your chamber enlargement overall. Let me know in the comments whatever doubts you have, and stay tuned to the next most important topics of LV and RV enlargement. Let's get on with it. Please leave a like, comment, and share your thoughts, your doubts in the comment section. And do subscribe to the channel for further such videos. And hit this link to get me on Instagram, where I speak about more aspects of fitness, health, cardiology, and much more. Thank you.